Dr. Jagdish, thank you so much for this kind introduction. My sincere thanks to the Fever Foundation and to Dr. Manjula Suresh for sort of giving me this opportunity to share my 2 cents on the role of AI in the healthcare space. I would like to share my screen, please. Going to touch on is the need for artificial intelligence. What is AI and how is it built? Just give a top-level synopsis of what this is all about. What are the different types of AI that we get to know? Where are the possibilities where we can deploy AI? And of course, in conclusion, saying, does the most often asked question saying, can AI replace paramedics and doctors, is something that I would also want to touch upon in my conclusion. With that, if we really look at the global healthcare challenge, we find that 1 out of 3 people will be diagnosed by cancer in their lifetime. 500 million people suffer from respiratory diseases. 400 million people have diabetes, and an estimated 1 billion adults are expected to have hypertension. The demand for care is always going to grow, and the shortage of healthcare professionals will also increase exponentially. According to United Nations, the world's population is expected to increase by 1 billion by 2025, and out of that, 300 million people will be 65 years or old. If we push that into 2050, we find that there will be almost 2 billion people over 60 years of age, and about 390 million people will be 80 years of age plus. The Brookings Institute also estimates that about 65% of the global population will be in the middle class by 2030, who will be demanding quality care. The world has a shortage of 12.9 million healthcare workers by 2035, and today that figure stands at 7.2. If you look at the spending, US spends 17% of its GDP in healthcare, and EU spends 10% of its GDP. Now, if you look at the magnitude of the problem that these are problems that are of significantly high intensity, and a normal tactical solution of what we have been doing so far is not going to help us. If we really look at this photo, which I shot in Shanghai, you find that the number of people, this is an OPD clinic. It reminds me of Dr. Guleria's All India Institute, where we have almost 10,000 patients a day. This is a case in China where you find that the number of patients is significantly large. And number two, what is more worrying is that the age of the patients is coming down. You see a lot more younger patients out there, which is a cause of concern. So if we really look at it, what are the challenges that we are having in the healthcare world? One is availability, that is lack of adequate infrastructure and skilled personnel to deal with this problem of this magnitude. Accessibility, we also talked about it. In fact, Dr. Guleria touched on this unequal distribution of care, which is so prevalent, not only in the vaccine, but also in the healthcare ecosystem. Increasing cost of care and affordability, given the fact that even in places like India and other developing geographies, a lot of it is out-of-pocket payment. The insurance has not penetrated the way we get to see in a Western world, is also sort of driving family to bankruptcy. Awareness, delay in early diagnosis, and of course, chronic diseases and the lifestyle diseases are on the rise. So when you look at the macroeconomic factors, you find that the conventional approach to solve the problem is not going to be helpful. Increasing the hospital beds, increasing doctors, increasing nurses, increasing the spend in GDP is not going to really help us. I think we need to look at methods wherein we can do more with less. And that's where exponential technologies actually come in. I was surprised when somebody told me, saying that when you walk across the room and you take 30 linear steps, you move from one point in the room to the other point. Whereas if you took 30 exponential steps, you would be walking around the planet 26 times. You know what? I actually did this calculation to ascertain to myself that this is indeed true. And lo, it was the fact. So what we really need to look at is exponential technologies which can help solve the problems, which otherwise is going to be very, very difficult in dealing with problems of these magnitudes. So one of the exponential technologies that we are looking at is artificial intelligence. What is artificial intelligence? It's basically a combination of artificial and intelligence as applied to machines and not to humans or any other animals for that matter. So if I sort of just read this out, artificial intelligence is that exhibited by machines rather than humans. It defines as a study of intelligence agents, any device that perceives its environment and take actions that maximizes its chance of success in a given system. So what we are now trying to do is trying to use machine and the computational power that is now available to see how we can dispense care and take it to the next level of success, so to say. So when you look at artificial intelligence, what are the common assets that one gets to look at? It could be imaging data. It could be waveforms like what we get to see in an ECG. It could be clinical notes and prescriptions. It could be critical care monitoring data, which comes out of a critical care monitor, or it could be the pathology. It could be the slides and the data that goes along with it. Add to that the genomic information and the molecular information. So this is basically the whole AI. These are basically the assets that are available to us based on which we could make diagnosis. So if I really look at a life cycle at how is an AI actually developed, there are multiple things that we need to appreciate here. First one, there is a volume. Volume is something that we look at, which is basically the scale of data. You look at the velocity, saying how often and how much of data is actually coming into the system. The variety of data that we looked at, it could be an ECG report, it could be a EMR record that comes in, it could be the contraindications, it could be the biogram, which talks about the susceptibility to antibiotics. And on top of this, there is also a certain amount of uncertainty in the data that comes in, which is called as the veracity. So basically what we do here is we collect the data. The data is curated. That is, we ingest the data, we clean the data, understand that we are able to sort of create some ground rules for it. Then there is what is called as a feature extraction, which is basically feature creation, feature selection. And we also use the clinical domain expertise to try and understand what it takes to build a particular algorithm. Then you use the data modeling and the validation, which involves machine learning, which involves deep learning, compute intensive training and iterative training and stuff like that. And then once the model is developed, you are then able to sort of take it for clinical validation to see if it really serves the intended purpose and take it through the CE process, the FDA process, just so that you are sure that it conforms to all the regulatory needs. And then the best way is to sort of then take it and integrate it into the hospital workflow in order to assist the doctors and the caregivers in terms of easing out which is basically the intended purpose of the algorithm. So this is basically how an algorithm actually gets developed. Typically, we find that a bulk of the time is spent in cleaning and preparing the data, and then an equal amount of time is spent in validating the data. Like 45 to 50% goes in preparing the data. You've got about 20 to 30% in validating the data, and then about the last 10% is on integration. So developing the algorithm per se is only 1/3 of the process. The balance 2/3 is about how do you collect the data and how do you sort of validate it. There are different types of AI solutions that we get to look at. Let's start with the descriptive analytics, which is basically saying it will tell you, study the data from the raw data and describe what has actually happened. The next step towards measuring the technology is called diagnostic analytics, which basically tells us, saying it compares the coexisting trends of movement, uncovering correlations between variables, looking at causal relationship, and answers the question, why did that event happen? Then you get into predictive, which says what might happen into the future, and the prescriptive, what should we do next to prevent any of this from happening. So even in the analytics, in the world of analytics and AI, there's an evolution that we get to see. At this point in time, I would I would dare to say that we are more looking at the descriptive analytics and diagnostics in some cases. We are far away from preventive and prescriptive analytics in that sense. We also look at, there are multiple data that comes up, which is called as deep data, wide data, dense data. People talk about it all the time. Like, for example, let me give you some examples. When I look at an MRI or a CT scanner, which has now become digital, we can obtain much sharper images that gives us detailed information than ever before. Today, we can unleash the power of managing health at a population level by virtue of dense data. We can perform risk stratification on population level and implement preventative health programs for those at risks. With a vast amount of data, we can also do pattern recognition via machine learning and apply this, like, for example, in home monitoring or ambulatory care and ICU, where we can use and create preventative programs or therapies. And we also talked about working on personalized care plans that picks up abnormalities at a very, very early stage. These are the typical application of what a dense data can actually help us. And we also looked at wide data, which talks about new personal measurement devices, mobile diagnostics, sensor technologies, by which you are able to sort of look at a particular data set over an extended period of time, continuous monitoring over time, what we look at longitudinal records, and then draw inferences as to why it happened and what is going to happen. So if we look at the AI trends in the healthcare world, we are looking at, we talked about this, and this was also opined to by my earlier speakers. We talked about personalized treatment plan, where you can, treatment plans which are being customized by machine learning systems based on patient medical condition, their past history, and a specific need for improving efficacy. You could look at preventive treatments which are based on AI platforms and a patient medical history, along with environmental factors who are highly susceptible for developing illness, and therefore recommend treatment programs to them. Improved diagnosis, which are able to detect anomalies and with enhanced accuracies. You are able to sort of pick up the disease well before it actually manifests itself. And then you're looking at automated diagnosis, where technologies are being integrated into the diagnostic device for automating simple medical tests, which can be done without human intervention, relieving medical professional of non-core activities. Take, for example, the smartwatch, the Apple smartwatch. You can pick up a ECG, a 2-lead ECG equivalent out of it. And if you have fibrillation, there is a way by which you could alert your caregiver on saying that, yes, there is going to be a part of saying that I'm undergoing certain challenges, and it can contact your doctor, and a doctor respond back to you instantly without even you realizing that somebody has reached out to you on your behalf. So there are technologies that sort of help you dispense care automatically in a scenario where otherwise it could have been a life-threatening situation. Now, if you look at, like, for example, we always talk about cost, quality, and access. These are known as the iron triangle in healthcare, because once you try to optimize cost, you realize that your quality and access can get impacted. If you try to increase access, your quality and cost gets impacted. And if you try to increase quality, then you have got an impact on the others. And that is where solutions like artificial intelligence can actually come in and sort of support you. Take the case of virtual radiology. Suppose if I have a scanning center, say about 100 kilometers off in Chennapatna, I can take a technician can take the scan out there, push the scan into the net. The first level of diagnosis can be done by the AI tools, and at least do a first level of screening, saying, is it good, or is there a problem? Is it okay or non-okay? Is it normal or non-normal? Once that is ascertained, if it is a non-normal, it can then route it to the next radiologist who is available on the system, who can then report it out and get back to the clinic where the scanning was actually done with the report, and the entire turnaround time can be done in 45 minutes. Now, so basically what we are trying to do is, we know there is a shortage of radiologists in the country. We looked at that in the earlier slides. What we are now trying to do is to use the capability that exists in the cities to dispense care into the rural area. It is a typical hub and spoke model. So by doing so, you are ensuring that the one at the remote site gets the same quality of care as one who would have got in a premier a corporate hospital in any of the metros. That's one way. AI can significantly reduce healthcare costs to use of self-assessment tools, which can eliminate unnecessary inpatient doctor visits. The platforms can monitor patient at higher risk of readmission and in turn facilitating significant saving on the cost of care for the healthcare providers. There are systems which can predict disease in its early state, providing more accurate patient risk stratification and identifying a proactive course of action to treat them, thus bringing in new precedent in the quality of care provided to the patient. So there are multiple ways by which AI can help us solve the tangle that we are in terms of optimizing cost, quality, and access. We talked about patients with chronic conditions to self-manage. This is something that, thanks to Philips, we actually have this live and we have actually deployed it, by which patient with, say, a type 1 type 2 diabetes, we are able to use algorithmic detection to manage, look at their consumption, look at their insulin levels, and look at their activity level, the nutrition that they put in, and together come up with a treatment plan and also advices and coaching. And consequent to all of this, we find that we are able to reduce the cost of care by 26% and readmissions by about 52%. There are evidences for this, thanks to Philips. There are imaging-enabled products like, for example, we can do brain anatomy segmentation, that is delineation of anatomical structures of brain with volumetric images. We could do brain tumor segmentation, that is detection and segmentation of brain tumors from multimodal MRI scans. Cardiac MRI segmentation for segmentation of cardiac structures. Bone assessment, which is used in forensic science, wherein you can use the X-ray image for determination of skeletal age. And then, of course, you got the ligament tear detection for automatic detection of ligament tear in knee MRIs. And the list goes on. Adaptive intelligence can not only come in dispensation of clinical care, it can also come in the diagnostic side. Like, for example, how can I optimize speed? How can I enhance the patient experience? How can I do a more confident diagnosis? How can I bring in clinical efficiency into the system? And how can I drive operational efficiency? Like, for example, there are systems which basically keep looking constantly at the log of, say, an MRI or a CT or a cath lab, and looking at the parametric, the variations, they are able to predict as to if the machine is going to go down, and if so, on what account. And by doing so, you are able to plan your service well in advance, even before the machine shuts down. The other aspect is, like, for example, turning communities and homes into care settings. Dr. Devi Shetty keeps talking about this fact, which is so true, that at one point into the future, the hospital is going to be a place only for the ICUs. The balance of the care will be dispensed at home, because you have got so much of tools that are built into the devices and applications that are available around you, that the need to go and conserve the resource is done in a manner that the hospital beds is only used. The limited amount of hospital beds that we have is used only for ICU, and the balance of the care is done outside the hospital, because you also get far better outcomes given that you are being treated in a home environment. Of course, the patient monitoring at home and the care management at home also comes in, which is again which can be driven predominantly by the AI tools and the systems that we have. We talked about population health management. Clinical, behavioral, and operational data analytics can be done to sort of stratify where the population risks are, which are the at-risk population segments, and what interventions can be driven to drive positive outcomes in a manner that we want it to be. The next one is around biophysical modeling, and what I really want to do here is not talk about it, but actually show you a movie.
Imagine a future where personalized healthcare will provide every individual the right type of care, in the right way, and at the right time. A key enabler for this will be computational biophysical modeling. Let's look at an example of how this plays a significant role when Dr. Sullivan, a cardiologist, is treating Mr. Burke, who has been diagnosed with atrial fibrillation. Although AF is a highly prevalent disease, it can be complicated to decide on the individual treatment strategy for a patient like Mr. Burke. This is where biophysical modeling proves useful. It starts by using Mr. Burke's medical data to create a patient-specific biophysical model, including a virtual version of his heart, which looks, behaves, and reacts just like the real one. This biophysical model, combined with cloud data on similar cases, allows Dr. Sullivan to select ablation as the therapy with the best possible predicted outcome for Mr. Burke, both on the short and on the long term. Dr. Sullivan carefully plans the procedure by simulating various ablation scenarios on Mr. Burke's virtual heart model. She is then able to select the one with the optimal computed result. The chosen ideal scenario forms the basis for real-time intervention guidance. During the procedure, all taken actions, as well as any unforeseen situations, are processed real-time into the biophysical model to redirect if necessary. As a result, Dr. Sullivan could treat her patient at the right time, in the right way, with the best possible outcome. This is one of many potential cases in which biophysical modeling forms an essential building block for an optimal healthcare system. From personalized diagnosis and therapy selection to procedure planning and guidance tailored to the patient's physical characteristics, medical history, current condition, and future needs.
I come to my last slide, the oft asked question saying, can AI replace doctors? The answer is not. And this was also ascribed by Dr. Muruganathan, saying empathy cannot be replaced. There is no way, when you go to a physician, you look up to him a lot more than mere diagnosis and treatment. It's about hope, compassion, trust, expressing the feeling of understanding with an appropriate response, good counsel. These can never be replaced. Physicians have a non-linear working model. Let me sort of relate this case to you. There was a guy who was diagnosed with poisoning. They considered many different options: drugs, food poisoning, pesticide poisoning. Every possible diagnosis, they suggested different treatment options. Some of them made the patient worse. Then they figured out that the boy picked up a material called phosmet, a type of insecticide from the genes that he brought from a street vendor, which was kept in a truck which carried fertilizer earlier. Any amount, the boy did not actually wash the gene, he just wore it, and through that skin absorption, he got poisoned. Any amount of AI will not be able to detect this. It does require a human brain working in nonlinear fashion to make this happen. Complex digital technologies require competent professionals. The brain is so complex that it might be futile, if not impossible, to recreate it. So let the brain do its job and let the machine do more of the repetitive stuff that it is more adept at. And it has always been a tech versus, it has never been a tech versus human. It is always a tech with a human combined that has so far made the difference for mankind. Even if we look back at the scientific advancement. So overall, suffice to say that what we really need to do is to AI enable the doctor rather than looking at AI as the replacement for the doctor. And with that, I come to the end of my presentation. Thank you once again for hearing me out and giving me this opportunity to share my 2 cents.